Good morning, everyone. Today our topic of discussion is thyroid gland. In the last class, we have seen about overview of endocrine system. Now we are going into a discussion of thyroid gland. Classification of thyroid diseases. As we have seen in the last class, the endocrine diseases are classified as hormone excess or due to hormone deficiency or hormone resistance or non-functioning tumors. And the thyroid hormone excess may be due to Graves' disease, multinodular goiter, adenoma, or subacute thyroiditis. Hormone deficiency may be due to Hashimoto's thyroiditis or atrophic hypothyroidism. And hormone resistance may be due to thyroid hormone resistance syndrome. And non-functioning tumors include differentiated carcinoma or medullary carcinoma and lymphoma. Coming to functional anatomy, physiology and investigations. So in this figure we can see the pituitary gland secretes TSH. Pituitary gland secretes TSH, which acts on the TSH receptor, which is present on the follicular epithelial cells of thyroid to stimulate the synthesis of thyroglobulin. The thyroglobulin is secreted into the colloid, and there is iodine trapping. Iodine is absorbed from the apical basolateral membrane. There is a receptor known as sodium iodide symporter. Iodine is trapped into the follicular epithelial cells, and through the apical membrane there is a receptor which is coded by pendrin gene, and the defect in this pendrin causes Pendred syndrome. This iodine is taken up onto the tyrosine residues to form diiodotyrosine and monoiodotyrosine. This diiodotyrosine and monoiodotyrosine join to form T3, and two molecules of diiodotyrosine forms T4, and this T3 and T4 is taken up by endocytosis again into the follicular epithelial cells, and this undergoes dehalogenation. This excess iodide is dehalogenated, and this T3 and T4 is formed, which is taken up into the circulation. In the circulation, more than 99% is protein bound and less than 1% is free. This free hormone which acts to increase the almost entirely bound to transport protein, that is more than 99% it is bound to transport proteins. For example, thyroxine binding globulin, thyroxine binding albumin and prealbumin. Free hormones is that which is unbound, and it exerts divert metabolic actions. The circadian rhythm of TSH, the peak occurs at 1 hour and trough occurs at 11 hours, but the variation is small. So the blood sample taken at any time of the day is reliable, and it does not require any dynamic stimulation or suppression tests. The relationship between TSH and T4 is inverse log linear. That is, as a T4, here you can see, as a T4 increases, TSH decreases, and T4 decreases and TSH increases. What are the common patterns of abnormal thyroid function test results? In thyroid function tests, we do TSH, T4 and T3. If TSH is undetected, we should see for T4 and T3. If both T4 and T3 are raised, then it is primary thyrotoxicosis. If TSH is undetected and only T3 is raised, then it is T3 toxicosis. And TSH is undetected, T4 is raised but T3 is normal. It is seen in factitious thyrotoxicosis, that is exogenous excess administration of thyroid hormone, or it can be seen in non-thyroidal illness. And if TSH is elevated and T4 and T3 are low, then it is primary hypothyroidism. If it is raised but it is between 5 to 20, then it can be subclinical hypothyroidism. If it is much elevated, that is 20 to 500 milli international units per liter, that TSH is 20 to 500 milli international units per liter, T4 and T3 are normal, then it can be artifact or it can be due to heterophilic antibodies. What are heterophilic antibodies? Those are antibodies which are against the animal antibodies which are used in TSH assays. If TSH is elevated and both T4 and T3 are also elevated, then it can be due to thyroid hormone resistance. The other modalities commonly employed in investigation of thyroid disease include measurement of thyroid antibodies against TSH receptors, radioisotope imaging, fine needle aspiration biopsy, and ultrasound. These are the other investigations apart from thyroid function tests. What are the presenting problems in thyroid disease? The common presentation include hyperthyroidism or thyrotoxicosis, hypothyroidism, asymptomatic abnormal thyroid function tests, or enlargement of thyroid gland, that may be goiter or thyroid nodule. What is thyrotoxicosis? Thyrotoxicosis is constellation of clinical features due to elevated thyroid hormone. So what are the causes of thyrotoxicosis? It may be due to Graves' disease or multinodular goiter or solitary nodule, or it may be due to thyroiditis or iodine induced or extrathyroidal sources of thyroid hormone, that is factitious thyrotoxicosis, and it may be TSH induced, that may be due to pituitary adenoma or follicular carcinoma. So this slide shows the same causes of thyrotoxicosis. It may be primary hyperthyroidism, that is the defect is in the thyroid, that is Graves' disease, multinodular goiter or toxic adenoma, and thyrotoxicosis without hyperthyroidism, that is seen in subacute thyroiditis or silent thyroiditis, and secondary hyperthyroidism may be due to pituitary problem or due to hypothalamic involvement, that is TSH secreting pituitary adenoma, or it may be due to gestational thyrotoxicosis. What are the clinical features? Clinical features of thyrotoxicosis. Common symptoms include weight loss, increased appetite, heat intolerance, palpitations, tremors, dyspnea. Less common features like osteoporosis, diarrhea, steatorrhea, ankle swelling, periodic paralysis, and amenorrhea or infertility. And rare causes include vomiting, apathy, or anorexia. What are the signs of thyrotoxicosis? We can see palmar erythema, sinus tachycardia, goiter with bruit or atrial fibrillation, or hyperreflexia. There can be ill-sustained clonus, or there can be gynecomastia or a spider nevi. This slide also shows the signs and symptoms of thyrotoxicosis. All causes of thyrotoxicosis can cause lid retraction and lid lag due to sympathetic innervation of levator palpebrae superioris muscle. But what is the difference between the thyrotoxicosis due to Graves' disease and due to other causes? In Graves' disease, along with lid lag and lid retraction, there is ophthalmopathy, including periorbital edema. There may be conjunctival irritation, exophthalmos, and diplopia. There is pretibial myxedema, and rare thyroid acropathy may be present in Graves' disease. This figure shows thyrotoxicosis due to Graves' disease. You can see proptosis, conjunctival injection, and there is pretibial myxedema and thyroid acropathy. What are the first line investigations? We perform T3, T4, TSH, that is thyroid function tests. When biochemical thyrotoxicosis is confirmed, then we go for measurement of TSH receptor antibodies and radioisotope scanning. What are the non-specific lab abnormalities in thyroid dysfunction? In thyrotoxicosis, there may be raised ALT, raised GGT, and raised alkaline phosphatase, or there may be raised bilirubin, and there may be hypercalcemia and glycosuria. ECG shows sinus tachycardia and atrial fibrillation in thyrotoxicosis, and radioiodine uptake tests are now superseded by technetium scan, that is 99M technetium scintigraphy scans. So this slide shows approach to the patient with thyrotoxicosis. When you see the features of thyrotoxicosis, that is symptoms and signs, you go for thyroid function tests. In thyroid function tests, if T3 and T4 are raised and TSH is suppressed, first you should rule out non-thyroidal illness. And Then you should look for features of Graves' disease, as we have discussed earlier just now, that diffuse goiter with bruit or ophthalmopathy or pretibial myxedema and positive TSH receptor antibodies. Then if these features are not present, then we go for thyroid scintigraphy. If these features are present, and features of non-Graves thyrotoxicosis we should look for, that is any recent pregnancy or within last 6 months, and neck pain or flu-like illness, and any intake of drugs like amiodarone or T4, and palpable multinodular goiter or solitary nodule. If these features are not present and features of Graves are present, then it is clear-cut Graves' disease. If features of Graves' disease are not present, we go for thyroid scintigraphy. In that, if there is low uptake of low uptake, then it is low uptake thyrotoxicosis, that is due to transient thyroiditis or extrathyroidal T4 source. If there is localized uptake, then it is toxic adenoma, and diffuse uptake, it is Graves' disease, and this is multinodular goiter. What is the management? Definitive management of thyrotoxicosis include anti-thyroid drugs like carbimazole, methimazole, or propylthiouracil, radioiodine, or surgery. A non-selective beta blocker like propranolol or nadolol decrease symptoms in 24 to 48 hours. This is generally used for short term. It is not for long term treatment of thyrotoxicosis. So atrial fibrillation, we have seen in symptoms and signs that atrial fibrillation is a feature of thyrotoxicosis. How do you manage? This atrial fibrillation is seen in 10% of patients with thyrotoxicosis. Incidence generally increases with age. It is commonly seen in males over age of 60 years. It responds to beta blocker. Thromboembolic complications are generally seen in atrial fibrillation, AF, and thyrotoxicosis, for which anticoagulation is required unless it is contraindicated. This atrial fibrillation reverts to sinus rhythm in 50% of the cases. If it is not reverted, then we go for cardioversion. Coming to thyrotoxic crisis or thyroid storm, it is life-threatening. It is a rare condition, but it is life-threatening. What are the features of thyroid storm? We see the signs like fever, agitation, delirium, that is acute confusional state, tachycardia or atrial fibrillation, and in older patients we see cardiac failure. Budge-Watofsky system is used to establish the diagnosis of thyrotoxic crisis. Barshwatovsky scoring system for thyrotoxic crisis includes measurement of temperature. This scoring is given for each feature. We look for temperature and any central nervous system features like delirium, psychosis, or seizures or coma, or if there is any involvement of gastrointestinal system in the form of diarrhea, nausea, vomiting, or abdominal pain, or any unexplained jaundice, and cardiovascular system involvement in the form of tachycardia, atrial fibrillation, congestive heart failure, and the scoring is given, and if the score is more than 45, then it is likely thyrotoxic crisis. If it is between 25 to 44, then it is impending thyrotoxic crisis. If it is less than 25, then it is unlikely to be thyrotoxic crisis. Thyrotoxic crisis is precipitated by infection and thyroidectomy in ill-prepared patient, and after iodine 131 therapy due to radiation damage to the thyroid. How do you manage a patient with thyrotoxic crisis? We give propranolol either orally or intravenously, and sodium iodate. It reverses T3 levels within 48 to 72 hours. It is more effective than potassium iodide or Lugol's solution. The mechanism of action is it concentrates in the thyroid follicular cells and it inhibits the conversion of T4 to T3. And it also inhibits the release of thyroid hormones. And dexamethasone and amiodarone have similar effects. These are also used in management of thyrotoxic crisis. Oral carbimazole 40 to 60 mg daily is given, and if the patient is unconscious, then carbimazole can be administered rectally. There is no parenteral preparation available for carbimazole. After 10 to 14 days, these patients can be usually maintained on carbimazole alone. Coming to hypothyroidism, we have seen hyperthyroidism or thyrotoxicosis. Now we'll discuss about hypothyroidism. What are the causes of hypothyroidism? Autoimmune causes include Hashimoto's thyroiditis or spontaneous atrophic hypothyroidism. Iatrogenic causes including thyroidectomy or radioactive iodine ablation, and transient thyroiditis or iodine deficiency. Congenital causes including dysharmonogenesis or thyroid aplasia. Infiltrative disorders of thyroid, that is amyloidosis or sarcoidosis. And secondary hypothyroidism due to TSH deficiency or defect in the pituitary. This is the same thing. Causes of hypothyroidism, it may be primary defect in the thyroid itself, that is autoimmune hypothyroidism. And transient causes like silent thyroiditis or subacute thyroiditis. Secondary causes include hypopituitarism, that is the defect in the pituitary, or hypothalamic diseases. Coming to clinical features of hypothyroidism, these clinical features are opposite of hyperthyroidism. There we see weight loss, here we see weight gain. There we see heat intolerance, here it is cold intolerance. And there is fatigue, somnolence or dry skin, dry hair. There may be menorrhagia, and there is constipation, hoarseness of voice, there is alopecia, there is carpal tunnel syndrome, and there may be deafness or depression or infertility. The signs we see are purplish lips, malar flush, there is periorbital edema, there is loss of lateral eyebrows, there may be anemia, or there is delayed relaxation of reflexes, there may be pericardial or pleural effusions. Signs and symptoms of hypothyroidism, the same thing. This figure shows female with hypothyroid features, facial puffiness, periorbital edema. This is approach to the patient with hypothyroidism. When you see features of hypothyroidism, that is symptoms and signs, then we go for thyroid function test. In thyroid function test, T4 is low and TSH is high. First, we should rule out non-thyroidal illness, And next, if TSH is less than 20, look for any features of secondary hypothyroidism, that is due to pituitary gland. Is there any pituitary gland involvement? If no, then see for features of any transient thyroiditis, that is neck pain, or less than 12 months postpartum, or any recent symptoms of thyrotoxicosis, or less than 6 months of iodine 131 treatment or thyroidectomy. The ultimate aim is to know that if thyroid replacement is required as permanent or temporary. In features of transient thyroiditis, it is temporary replacement. And next step is find out whether the patient is on any drugs like amiodarone and lithium, because in these patients the T4 replacement is required as long as the patient takes these drugs. And next step is ask for the patient, has he undergone any thyroid ablation or thyroidectomy, because in these cases there is requirement of permanent T4 replacement. And in similarly in Hashimoto's thyroiditis also there is permanent T4 requirement. Coming to investigations, we have seen just now that T4 is low and TSH is high. Usually it is more than 20 milli international units per liter. Secondary hypothyroidism is due to defect in the pituitary or hypothalamus. There is failure of TSH secretion by the pituitary. What are the features in ECG? In ECG, in hypothyroidism, we see sinus bradycardia or low voltage complexes and ST segment and T wave abnormalities. There are thyroid peroxidase antibodies present. What are the non-specific lab abnormalities in thyroid dysfunction? In hypothyroidism, we see raised creatine kinase, aspartate aminotransferase is elevated, and LDH is elevated. There is hypercholesterolemia. There may be anemia. It may be normocytic, normochromic, or macrocytic, and there is hyponatremia. How do you manage a patient with hypothyroidism? We give levothyroxine replacement. Usually it is the levothyroxine dose is 1.6 microgram per kg body weight. Usually we start with 50 micrograms per day for 3 weeks, and after that we increase the dose as per the requirement. And in younger patients, it is safe to initiate with the higher doses. As levothyroxine has half-life of 7 days, it can be given as a single dose, and at least 6 weeks after the starting of dose, we should repeat thyroid function test, because TSH takes several weeks to reach this steady state. After starting the treatment, generally patient feels better within 2 to 3 weeks, and there is reduction of weight and periorbital puffiness quickly, but restoration of skin and hair texture usually, and resolution of effusions takes 3 to 6 months. It takes long time. The dose of levothyroxine should be adjusted to maintain the TSH within the reference range. Once it is stabilized, then thyroid function tests are repeated every 1 to 2 years. The situations in which the adjustment of dose of levothyroxine, Abhishek. Situations in which adjustment of the dose of levothyroxine may be necessary is increased dose requirement. When is levothyroxine dose required in increased doses? That is when the patient is on drugs which increase T4 clearance, that is phenobarbital or phenytoin, and which decreases intestinal T4 absorption like cholestyramine, sucralfate, or aluminum hydroxide. And in pregnancy also there is increased dose, because there is increase in thyroxine binding globulin, and in malabsorption cases. And when is dose a decreased dose required in aging, because there is decreased T4 clearance. Levothyroxine replacement in ischemic heart disease. In ischemic heart disease, generally this hypothyroidism and ischemic heart disease are present concomitantly. In these cases, there is low dose requirement. It should be started in low dose and it should be increased very slowly. If there is angina present on levothyroxine replacement therapy, then we should go for coronary intervention. Hypothyroidism in pregnancy. In previous slide we have seen in pregnancy there is increased requirement of doses. Generally 50% of the pre-pregnancy dose excess is needed in pregnancy. That is, we add 25 to 50 micrograms and we adjust according to the TSH values and symptoms. If it is inadequately treated, then there may be impaired brain development in fetus. Myxedema coma. Myxedema coma is very rare presentation of hypothyroidism. There may be depressed level of consciousness, and in elderly patients it is usually present, and the patients are usually myxedematous. Body temperature may be as low as 25 degrees centigrade, and convulsions may be present, and there is increase in CSF pressure and protein content in CSF are also increased. Mortality is generally 50%. We should recognize it early and treatment is started, and we should also look for other factors for reduced consciousness level, that is any medication is present, or cardiac failure, or pneumonia or respiratory failure. Myxedema coma is medical emergency. The treatment must begin before biochemical confirmation of diagnosis. Generally, the treatment is given with intravenous 20 microgram liothyronine. It can be given 3 times daily. Generally, body temperature within 24 hours, there is rise in body temperature. After 48 to 72 hours, it is usually possible to switch patients to oral levothyroxine in dose of 50 micrograms. Unless it is apparent that patient has primary hypothyroidism, this thyroid failure should be taken as a cause of pituitary or hypothalamic disease. The treatment is given as hydrocortisone 100 mg IM 3 times daily, and before the result of T4, TSH and cortisol measurement. And other measures of treatment include slow rewarming, cautious use of intravenous fluids, broad spectrum antibiotics, or high flow oxygen. So next, coming to asymptomatic abnormal thyroid function tests. That is, thyroid function tests are abnormal and the patient is asymptomatic. These can be 3 categories. That is subclinical thyrotoxicosis, subclinical hypothyroidism, and non-thyroidal illness or sick euthyroidism. Subclinical thyrotoxicosis. Serum TSH is undetectable as seen in thyrotoxicosis, but T3 and T4 are in the upper range of normal reference range, upper end of reference range. Most often it is seen in older patients with multinodular goiter. These patients are increased risk of atrial fibrillation and osteoporosis. They require iodine 131 treatment. Conversion rate to overt thyrotoxicosis with elevated T4 and T3 is 5% each year. Coming to subclinical hypothyroidism, serum TSH is raised, but T3 and T4 are lower end of reference range. When do you treat subclinical hypothyroidism? If there is positive autoantibodies and TSH greater than 10 milli-international units per liter, generally we treat, because if we do not treat, they may present to us in future with profound hypothyroidism. Non-thyroidal illness or sick euthyroidism. In this, there is low TSH, high T4 and low T3. Why is this present? There is decreased peripheral conversion of T4 to T3, and there is decreased secretion of TSH by pituitary. As thyroid function tests are difficult to interpret in patients with non-thyroidal illness, it is wise to avoid performing thyroid function tests unless you suspect a thyroid disease present in non-thyroidal illness. Thyroid lump or swelling. Causes of thyroid gland enlargement. It can be diffuse goiter, or it may be multinodular goiter or solitary nodule. Diffuse goiter may be simple goiter, or it may be Hashimoto's thyroiditis or Graves' disease. Solitary nodule may be colloid cyst or hyperplastic nodule, or follicular adenoma, or papillary carcinoma. Multinodular goiter and solitary nodule sometimes present with acute painful enlargement due to hemorrhage into nodule. Only 5 to 10% of thyroid nodules are malignant. A nodule presenting in childhood or adolescence with past history of head and neck irradiation, or presenting in elderly patient, should heighten the suspicion of primary thyroid malignancy. The presence of cervical lymphadenopathy has also high likelihood of malignancy, and rarely secondary deposit from renal, breast or lung carcinoma may present with painful, rapidly growing solitary thyroid nodule. Clinical assessment and investigations. First, coming to the broad differential diagnosis of anterior neck swellings. Anterior neck swelling differential diagnosis include lymphadenopathy, branchial cysts or dermoid cysts, and thyroglossal duct cysts. First, ultrasound scan should be performed, and T3, T4, TSH levels should be taken. Thyroid scintigraphy. Thyroid scintigraphy with 99M technetium should be performed in individual with low serum TSH and nodular thyroid. You should differentiate, is it hot nodule or cold nodule? There is increased secretion in hot nodule and no secretion in cold nodule. Cold nodules has high likelihood of malignancy, but majority are benign, so scintigraphy is not routinely needed. Thyroid ultrasound. Ultrasound can establish whether the thyroid is generalized or localized swelling. In inflammatory disorders causing diffuse goiter such as Graves' disease and Hashimoto thyroiditis demonstrate a diffuse pattern of hypoechogenicity. In Graves' disease, there is also increased blood flow on color flow Doppler. The presence of thyroid autoantibodies will support the diagnosis of Graves' disease or Hashimoto's thyroiditis. The absence in younger patient with diffuse goiter and normal thyroid function, it indicates diagnosis of simple goiter. Ultrasound can readily determine the size and number of nodules within the thyroid and can distinguish solid nodules from cystic element. Ultrasound is a key investigation in defining risk of malignancy in a nodule. The size of nodule is not the predictor of risk of malignancy. Then what are the features which indicate the risk of malignancy? Those are hypoechocity, intranodular vascularity, presence of microcalcification, and irregularity and lobular margins. In this figure, we can show this. We can see this is irregular margin and there is microcalcifications. This indicates malignancy, and in this figure we can see the cystic elements and it is a rounded definite margins. This is a benign lesion. A purely cystic nodule with spongiform appearance is generally benign. Individual nodules with multinodular goiter has same risk of malignancy as solitary nodule. Coming to fine needle aspiration cytology. When you do FNAC, if on radiology, radiological examination, if it is indeterminate, it is suspicious of malignancy, then we go for fine needle aspiration cytology. It is OP procedure, it is done under outpatient procedure, and it is done under ultrasound guidance. Aspiration may be therapeutic for a cyst. If the cyst recurs on FNAC, then we go for surgery. Fine needle aspiration cytology, generally it cannot differentiate between follicular adenoma or follicular carcinoma. In 10 to 20% of the cases with FNAC, inadequate specimen is obtained. How do you manage thyroid swellings? When suspicion of malignancy is low, then patient can be reassured and he can be discharged. In low iodine intake areas, levothyroxine therapy in doses that suppress serum TSH may reduce the size of some nodules. But this should not be the routine practice in iodine sufficient populations. Nodules that are suspicious for malignancy are treated by surgical excision, either by lobectomy or thyroidectomy. Nodules that are radiologically or cytologically indeterminate also are ended up in surgical excision. A diffuse or multinodular goiter may also require surgical treatment for cosmetic reasons, or if there is any compression of the local structures causing stridor or dysphagia. Iodine 131 therapy causes reduction in size of multinodular goiter. Levothyroxine therapy may shrink the goiter of Hashimoto disease, particularly if TSH is elevated. Next, in the next class, we'll discuss the leftover topics.
हेलो नहीं, मैं आर्टर में आया पुरुषोत्तम लैब को गया, सेंट्रल लैब।